Sorry for my partner and I. Right. We'll go ahead and assess my scene. Is my scene safe? They'll tell you your scene's safe. Alright, my mechanism of injury. What is my mechanism of injury? You'll get a mechanism of injury.
Fell out of a tree.
Alright, fell out of a tree. My mechanism of injury is a fall. Or do we know how high he fell or what he landed on?
20 feet.
20 feet? Alright. Based on the mechanism of injury, this patient does have a significant MOI. Alright, we're going to number of patients. I only have the one. Alright, I have one patient. And this time, because I only have one patient, my scene is safe. I don't need any additional resources. This is something my partner and I can handle. Right. We'll go ahead at this time, and this is where you can switch things up. I can have you do it, or I can do it. All right, I'll go through the steps of everything. All right. This time I'm going to go up, and I'm going to assume C-spine on my patient. All right, hey, buddy, are you all right? Are you okay? Do I have any response to verbal?
No.
All right, this time I'm going to pinch his earlobe. Do I have any response?
He twitches.
I get a twitch, so he is alert to painful response. All right, is my airway open?
He has an airway.
Is it patent?
It is patent, but he has shallow breathing.
All right. What is my respiratory rate, rhythm, and quality?
Respiratory rate, 48.
Yeah, 48, deep and shallow.
48 deep and shallow. All right, this time I'm going to have my partner go ahead and take over C-spine for me. And again, initiate BBM on 15 liters, one breath every 5 to 6 seconds, assisting with his breathing. And I'm going to move down. You said 48 and shallow?
Yeah.
All right, is I exposed? Do I know any injuries or any life threats to my thoracic cavity?
No.
No? Okay. I'm going to go ahead and move on to my assessment of my circulation. Do I have radial pulses?
Oh yeah, that's nice.
Do, but they are
weak and thready.
Weak and thready. All right, what is my skin color, condition, and temperature?
cold.
Pale.
All right, pale, cool, clammy. All right, at this time, based on his accelerated respiratory rate and his pulses, skin color, condition, temperature, this patient, I'm going to assume, is in shock, so they are a priority transport. Before we transport, I am going to perform a rapid secondary assessment because he is unresponsive and a significant MOI. All right, so as I begin my rapid head-to-toe assessment, if I could get additional personnel to get a baseline set of vitals and try to obtain any type of sample history I can get from the bystanders, and I'm going to start my head-to-toe. As I come to the head, do I note any DCAP, BLS, or any injuries to his head? If not, do a quick palpation for any tenderness, instability, crepitus, or anything in the face. Right. Move down to the neck. I'm going to inspect the neck for DCAP, BLS. I'm also checking my neck veins for JVD and my trachea for midline. While I'm here, I'm going to take a quick look for any medical alert tags, and I'm going to palpate as well for tenderness, instability, and crepitus along the back and the sides of the neck. All right. Feeling at the same time for any possible subcutaneous emphysema. Anything I note, I would treat at this time. Once I'm done, apply appropriately sized C-collar. Please still maintain inline stabilization until we get them secured to the backboard. Come down to my chest. Is there anything I didn't notice before? Any DCAP, BLS, or anything to my chest area? This time I'm going to assess the stability of my chest wall. DCAP, BLS, I looked for, and I'm assessing for tick. If I noted anything at that time, any flail segments, I would immediately put a gloved hand over top, have a secondary personnel stabilize with a bulky dressing, any other injuries I would find. Come down to the abdomen. Again, I'm going to look, DCAP, BLS, and then I'm going to assess for tenderness, rigidity, distension, or pulsating masses by palpating all 4 quadrants. If at any time I notice any pulsating masses or any pain response from him, I'll stop palpating and note it for later. All right, come down and expose the lower extremities, remove all the clothing. Do I note any DCAP, BLS, or obvious deformity to my pelvis? If not, I'm going to go ahead and test the stability of my pelvis. If at any time I note any pain response from him or any instability, I'm going to have a secondary rescuer go ahead and secure that and stabilize my pelvis. Come down to the lower extremities, which are already exposed. Do I note any DCAP, BLS on either of my lower extremities? And I'm going to assess for tick. Tenderness, instability, and crepitus on my left lower extremity.
You notice crepitus?
Femoral fracture.
All right, if I notice crepitus, I'm just going to note it because I'll deal with it later if I have time. Same thing on the left. All right, check the left lower extremity, and now I'm down to here. Do I have a pain response as well down here?
No, he cannot feel that.
Not feel that? Do I have pulses present?
Don't have pulses.
All right, I have pulses, no motor sensory. On my lower extremities, I'm going to come up to my upper, being exposed if it hasn't been already. Check my right and my left for any DCAP, BLS that I might see, and feel for tenderness, instability, and crepitus. Same thing on the right. And pulses, are they present and equal?
Pulses are present.
Pulses are present. Do I have any response from him here?
He twitches and moves slightly.
All right, so we do have motor sensory response here. At this time, he is showing signs and symptoms of shock, and I do suspect some type of spinal injury given the fact that he has no sensory motor in the lower. I have an additional rescuer help me here. On the headman's count, we're going to roll him over.
Ready? 3, 2, 1, go.
Once we have him here, we're going to slide a backboard in, and I'm going to assess the back. By noting decap BLS all the way down from the head to the feet, and I'm going to walk the spine, feeling for any deformities or any instability or crepitus along the spine. If I note anything or not, guess what? I can't fix it. I'm just noting it. We're going to report it later. Backboard in place on headman's count. 1, 2, 3, roll him over. All right, we're going to secure him down, and we're going to get in the back of the ambulance. Once we're in the back of the ambulance, we're going to reassess ABCs, get a secondary set of vitals, and continuously reassess en route, managing things we might find. If I have time, I'll go back and fix the fracture to the extremity, anything else I might have found, and continually reassess during transport.
That's what I was going to ask. Once you're in the ambulance and you've done all that, can you go ahead and splint that?
You can, if you have time. Again, it's that we're not worried about.
That took you 6 minutes.
Yep. You have 10 minutes to do it.
You got 10 minutes.
I know, but I'm saying if he was able to do it and then it took him 6 minutes.
Exactly. So how long?
Exactly.
10 minutes. Thanks, Brad.
All right, so it's this you're not worried about. All right, that tib fib you gave me, we're not worried about. All right, with that, when you get in the back of the ambulance, your biggest concern is ABCs and status. All right, if you have time, again, what works as a great splint.
The other leg.
Boom, backboard, strap, he's splinted. Whole body splint, he's good to go. That lower leg, if my ABCs are controlled and he's stable, I could consider splinting that if I have time. Outside of that, again, if he's not stable, I'm not worried about that fracture. I'll deal with it later. I'm worried about here.
Yeah,
what
say,
about a femoral fracture that isn't going through the skin?
yeah,
Like,
say
it's
that.
just a
Femur
simple
fracture.
Is it going to kill him right now, technically? If he's a multi-system trauma patient, backboard splint, rock and roll, get out. If that's an isolated femur fracture, then
Say
we're
it's
going to
protruding.
get a traction splint on it, and we're going to treat it. All
Well,
right.
say what
If he's a multi-system, like he fell out of the tree and he's only alert to pain and breathing shitty and circulatory systems in the dumps, I'm not worried about his femur. All right. I'm going to make sure his ABCs are good and I can go to the femur later. Because splinting, yes, does help control hemorrhage. All right. But if he's not breathing good, I need to worry about his breathing and assess that and get that under control and come back to my femur later.
What about if it is a compound fracture with the femur and it actually is going through the skin?
Then you just patch it up and go.
The femur, not the femoral artery.
The femur. That, in that situation,
Just patch it and go.
Because if it's the artery, then it'll be squirting everywhere that you have to worry about.
but when we get, now like I said, right now we're not too worried about treatment. Once we get through medical and we start getting into trauma, then we'll start throwing a dummy down or throwing each other down, and here's your scenario, go. And I'll throw injuries and things like that for you to treat as you go. Right now, get the steps.
Okay.
What are you looking for? And just note, if it's with airway, I'm going to fix it right now. Open his airway. I'll put an airway adjunct in. If he's not breathing right, and guess what? Trauma patients, they don't all need a BVM. Right? If he's breathing 14 times a minute in regular, all right, non-rebreather 15 liters. And I'm going to move on. All right? So they're not always going to need ventilation. All right? I've had patients with head injury. Right? Teeth clenched to where you couldn't get anything in if you wanted to. Depressed skull fracture sticking into his head.
Oh, shit.
And he was breathing 18 times a minute, give or take, and put him on 15 liters non-rebreather. He didn't need to be bagged. Right? So not always are you going to have to, it's a trauma patient, I need a BVM. Right? Sometimes non-rebreather is fine for them, but we have to assess that. Right? If their respiratory status is jacked, if they're breathing shallow or irregular patterns, we're going to help them because it's not adequate. But if it's adequate volume and rate, non-rebreather and move on.
What made him clench his teeth after he got hit in the head?
Brain injury.
Damn.
And didn't know it was a depressed skull fracture at the time until
Oh.
the next call, and when we looked at his CAT scan results in the CT room in the ER, and it was a spot about that big that was about like that far pushed into his
So, do the doctors actually give you results and everything if you ask for them?